You know, hard to do all your government work.
Hey, you don't know that.
And some chainsaws.
Hey, buddy.
How's it going, dude?
Yeah. It's all right.
Thanks for that shirt.
Yeah, no worries.
Come on.
Is Clay coming tomorrow?
Man, no.
Well, that's
Yeah, yeah.
The only place left in town.
Yeah. Okay, we're going to get started after 6 o'clock. So tonight we're covering two subjects, but we're not going to. It probably won't go the whole night. I got some other stuff to talk about after this that pertains to the subject matter, your guys' medical assessments and whatnot. But tonight is abdominal gastrointestinal emergencies. Remember, we have lab this Saturday, so 9 o'clock. We'll be in here because we're covering two chapters to start, and then we'll go do skills. And then we should be right on track with starting early today. We'll be right on track with the syllabus. And then we'll just move forward from there. So we've gone over A&P, a lot of this stuff. So hopefully some of this is just reinforcing what we've already gone over. However, we're going to go into some more detail with stuff that could happen in gastrointestinal and urological emergencies. There's some differences we're going to talk about briefly with people who are on dialysis. And we do have some of those people in the community. There's a dialysis center in La Grande. However, a lot of people just do it here. We can do peritoneal dialysis here in their home with machines and all of the liquids and whatnot. And there is some different stuff that we need to do with those patients, what could happen to them. And then, but they can have a lot of complications. When we get into this, you'll see that they're having a lot of shifts of their electrolytes, of things going on, fluid, gallons and gallons of fluid in their belly over the course of, whatever their cycles are throughout the day. And that can mess up their, potassium and things like that. Okay, so abdominal pain is a common complaint according to curriculum, and I'd agree with that. We go on a lot of abdominal pains. The problem with abdominal pain, especially at our level, is there's not a lot we can do about it. It's really hard to figure out where it's coming from, what's going on. So most of our care is just supportive. We're trying to get as many questions answered as we can as far as, and we'll go into these, what their history is, what they could have been doing, surgical interventions they've had, things like that. But really abdominal, even at the paramedic level, we might be able to give some pain medicine, give some fluid, whatnot, but it's really hard for us to determine what is causing abdominal pain. The good thing is, like it says there, we don't need to determine the exact cause. Our job in the field is stability, kind of start going down that route and then get them into the hospital. It's not really our job. We might have an idea. Like I said, if you have someone that has lower right quadrant abdominal pain, we're guessing maybe it could be the appendix, but we don't know for sure. But we can have some ideas. Okay, the abdominal cavity contains gastrointestinal system, the genital systems, urinary systems, and then also, before we get into the pelvic, like in females, reproductive, as a fetus grows and whatnot, it can obviously come up into that abdominal cavity as well. Made up of solid and hollow organs. That's important because depending on what type of organ is injured, is going to be maybe how your patient presents or what they're going to go through down the line with, with kind of maybe spilled out that organ, which will make sense in a second. Okay, you guys are going to want to write these down. These are common questions, like EMT questions. It might throw up there, which one of these organs is a solid organ or which one is a hollow organ. So you probably have a pretty good idea, but it's a good idea to have, these kind of memorized, or you can differentiate what's a hollow versus a solid organ. And then you can see there on one of my highlights, injury to a solid organ causes bleeding. Its significant problem is bleeding and shock if it's a solid organ that gets injured, whether from blunt or penetrating trauma.
Why is that, Don? Are the solid organs more vascular?
Yes. And it also the function of the solid organs, what they're doing. The spleen and liver, they're very vasculature, and their jobs are dealing with blood. So a lot of blood is going through them as far as filtering and stuff like that.
Right.
Where some of the hollow organs, like your intestines, they need blood, but their job is not dealing with blood, so they're not as vascular. But they come with a whole new set of problems if they get injured or ruptured.
So if we do our primary assessment, we think that there's a possibility that a solid organ is injured or something. We call that a life-threatening emergency.
Absolutely, because that will lead to, what's going to tell you? So the question is an injury to a solid organ considered a life-threatening injury? And I'm going to say yes, because what is telling you that it's a solid organ injury is that you're probably seeing signs of shock.
Yeah.
So you're seeing tachycardia, pale, which is leading you to believe what's going on inside. Bleeding, right. So if you're looking at the signs and symptoms that you're seeing and then deducing because they were hit with a baseball bat, they hit the steering wheel, that they have internal bleeding. So that would be life-threatening. Yep. Hollow organs might not be life-threatening right then, but they will become life-threatening, which you'll see in a second, for a different reason down the road. So hollow organs, gallbladder, stomach, small intestine, large intestine, urinary bladder. So again, my highlight there, the curriculum note, is breach of these hollow organs causes its contents to leak and contaminate the abdominal cavity. And then I wrote in there, so your patient could go septic, peritonitis, something like that, because urine, fecal matter, bacteria, all that stuff that's in your gut all the time is supposed to stay inside your small and large intestine. If it leaks out, then you have massive infection and things going on, which could lead to sepsis. So a lot of this we think about with trauma, but with these organs in particular, they can be susceptible to medical issues. And it's a real common complaint, especially in the elderly, might be like a twisted bowel, maybe one that's herniated, has gone somewhere and it's twisted, or it's through another cavity and now it's kind of impacted on itself and it's infarcting because there's too much pressure around it and blood can't get to that part that shot out of that other area where it's not supposed to be, you know, again, like a hernia. Valves can become twisted. If someone, like an elderly, becomes dehydrated, it's hard for them to have peristalsis, to have that valve move through them, and it can cause like a small valve obstruction. So you want to be thinking about some of the questions you might ask with abdominal pain, which we're going to go into in detail later. But a lot of stuff, especially on this list, actually most of this might be medical related. People go into cholecystitis or gallbladder infections, pancreatitis, things like that, pretty frequently. But having an understanding what causes these or what it could be is going to help you with your questioning, especially if we get into gallbladder and pancreatitis, what could kick those off to someone. So here's kind of a general idea of where these solid and hollow organs are. What's a difference with where these are lying in the abdominal cavity that you guys can maybe see solid versus hollow? Where are those solid organs at? They're up high. So some of them might be protected by what? Rib cage. There's a little protection there, where those hollow organs, the ones all down below, are kind of out in the open. The only thing protecting them is our 6-packs or 12-packs or whatever we might have.
Keg.
Your keg, yes.
It'd be kind of convenient because if you're doing your examination and you're doing your upper quadrants and you get upper quadrant pain, you kind of suspect maybe it's a solid organ.
There's definitely more of a chance, especially your liver right here or your spleen right here. Yeah, your liver's on the right side. Liver's on the right side, spleen's on the left. So yeah, if you have a seatbelt injury, a baseball bat injury up high, something like that, signs of shock, you could be pretty confident that you have involvement in one of those two organs for sure. Okay, so what the gastrointestinal system, what is it meant for? Is doing what you guys are starting right now, digesting this greasy, awesome fast food that we're eating. It starts in our mouths as we're chewing and the saliva is already lubricating and starting to break it down. It's swallowed, food travels to the stomach, and then as it passes through, all the way through it, our body's trying to get whatever nutrients and stuff out of it that we can. The stomach is the main digestive organ, which means it's breaking that stuff down. However, a lot of getting the nutrients and stuff out of it actually comes, in our stomach, but actually in the small and large intestines as well. This is where we try to derive some of that nutrients, whatever little there might be, especially in pizza. So the liver assists in digestion. The liver, gallbladder, pancreas are all secreting hormones, secreting bile, secreting things that are helping us break this stuff down, especially fatty food, which is where you can imagine some people have problems with their liver, especially their gallbladder, depending on their diet. If they eat a lot of fatty foods and they kind of overwork that, because it's trying to, you'll see later with some pictures I put in here, you'll see how that directly feeds into the duodenum where we're trying to break that food down. You can live without your gallbladder. A lot of people have it taken out because they develop gallstones or what's called cholecystitis, inflammation of your gallbladder. But if we try to keep it in there, it's pretty handy, pretty helpful. So particularly with the liver, filters toxic substances, creates glucose stores. So your liver, we can't live without our liver, and it's very important with our sugar regulation. Because if someone goes, it's like a hypoglycemic episode and they're given glucagon, what glucagon does is a hormone that tells the liver to release sugar, to stores of sugar to try to, it's like a last ditch effort to try to get that sugar back up. But your liver, pancreas, all of that is really important. Now we try to keep those intact. Filters toxic substances. So you can imagine what would happen if someone decided to take a whole big Kirkland bottle of aspirin or Tylenol. What's the organ that gets affected? It's your liver. And unfortunately, with those type of overdoses, it can take 2 to 4 weeks. So we go on a lot of people, especially younger, that whether they're trying to make a statement or they think it's going to kill them or whatnot, they overdose on aspirin or Tylenol because that's what's handy and available to them. And then, but it's very toxic to your liver. And it's a very painful, long process. You're either going to make it or you don't over 2 to 4 weeks.
I have a question.
Uh-huh.
I always got these confused. So Tylenol overdoses affect the liver. Ibuprofen overdoses affect the kidneys.
I have to look it up. I'm not sure. They all make it through the liver.
Okay.
So, but some might be more toxic to the kidneys. That I can't recall.
Okay.
Which one? Okay. So your small intestine, your duodenum, going into your jejunum. So here's where a lot of the digestion, and here's where we're trying to get the nutrients and stuff out of the food here. And again, I would think these always could be susceptible to trauma, but you're going to see a lot of people with medical problems related to these, maybe ulcers. These get twisted, they get bound up, whatnot. So again, we might not know that in the field unless someone tells you, oh, I've had a bowel resection or something like that. But even then, like we don't know what part of the bowel, unless they're really savvy, they'll just tell you I've had surgeries or whatnot. So here's just some parts I put in. So imagine that top part you see where the orifice there, imagine that's the stomach coming into it. That's the pancreas that's laying up next to it. You can see it's very vasculature through there. A lot of people, sometimes the sphincter between as it goes through, sometimes these things bound up, sometimes they don't work. There could be ulcers in here, duodenal ulcers, which could cause bleeding. Acid reflux, all that kind of stuff might originate from here. But the stomach would be above there, but it's just kind of taken out. And here's just the duodenum that will then go into one of the intestines. And that's kind of where it lays. So there's your duodenum, jejunum. And remember, this is different based on how you're laying, how you're sitting. If you're standing up, this stuff probably all falls to a different place. If you're sitting down, if you're laying down, it's all kind of rotating, moving around. But you can see that there's no protective structures. So very susceptible to injury, penetrating trauma, things like that. Okay, your small intestine, so your ileum, like it showed there towards the inferior part of that system. Also absorbs nutrients that were not absorbed earlier. So again, our body is an amazing thing. It's trying to keep us alive at every stage. Every body factor that we have is trying to do something to keep us alive. Here, it's at the last very bit of nutrients that it maybe didn't get. It's trying to absorb those out. Now, the problem with that though is in the event of an overdose or something, it's also absorbing all of that all the way down the line as well. So if you guys remember from your activated charcoal, after 60, 90 minutes, whatever it is that activated charcoal is not going to do any good anymore because the food's probably already in the system and already well down to before the charcoal is going to get to it, and the body's trying to get it out. So a real good question with your overdoses, your ingestions, someone took mushrooms. The good question is, when did you take these and how much on any type of stuff that someone might ingest?
Is there a golden window on overdoses? Because we have golden windows everywhere. Is there like, you just said 60, 90 minutes. We ask them, when did you take that? They say 20 minutes ago. Do we have a golden window to get them to the hospital?
Well, get them, yeah, because then that food is probably still in their stomach and maybe not all the way absorbed. So maybe they used to pump the stomach. A lot of people now, if we were in a bigger facility, because like you were saying, some of these things might affect the kidneys. They might just go, you're too late, you get to go on dialysis, and we'll see if you make it through it. But in 20 minutes, they might say, try charcoal, because at least it'll absorb some of it. If it's 90 minutes, they might not. Oh yeah, maybe pump the stomach if they still do that. So, and pumping the stomach that's putting an NG tube down, and then they put saline and charcoal down, and they sit there, and they literally in and out, trying to get that stuff out of your stomach.
Two-way system. one goes one way and it just kind of cycles back.
Yeah, but it's between saline and charcoal, and then they're trying to get that stuff out. Okay, the colon, food that is not broken down comes here. Peristalsis moves waste through the intestine, so that's like a wave of movement that is getting all that food and turning into feces as it goes down in the system. Okay, water is absorbed and then stool is formed. So guys, very important here, we need to be well hydrated for this system to work. I'm convinced that a lot of elderly people get ileuses and bowel obstruction and whatnot because they become dehydrated. Stuff gets to this point here and they don't have enough water, lubrication enough in this system, and stuff kind of dries up and bounds up right here. So we need to make sure that we're well hydrated. So again, another good question is, are you drinking plenty of water? Remember, whenever you ask, are you drinking enough? People are going to answer all kinds of stuff. So you need to differentiate what they're drinking. Some people live on alcohol. Some people live on Diet Dr. Pepper or water or juice. So make sure every question, you could have 2 or 3 follow-up questions to it, even something as simple as, are you drinking enough? Make sure it's, are you drinking enough water? Statistically, 75% of us don't have, we're walking around with a relative degree of dehydration. Okay, so here's your large intestine, goes up, around, and back down. You can see it does a lot of twists and turns, gravity, a lot of places that the stool, feces, food has to go through. So it's kind of amazing that it can work its way down through all of this. Okay, so here I threw that picture in. That's where the spleen kind of lies, up and back behind the stomach. No digestive function. It is lymphatic system, so it's a filter. So it's very vasculature, a lot of stuff's going through it. This one actually could give you both problems that we talked about because it's kind of collecting the garbage, the red blood cells, the white blood cells that are breaking down, whatnot. It's filtering through here, so you could have both if this was injured. A lot of trauma surgeons have no problem taking this out. We don't need the spleen. They'll take it out if they can't salvage it. They'll just take it out. But you can see there it has a lot of functions. Yeah.
Is the spleen the most popular organ to be damaged in accidents? It seems like it always.
I don't know statistically, but I know that it gets damaged a lot. I don't know.
Any reason why any particular, like, would we go over the scene and say, oh, this happened, oh, it might be a spleen, complaining about that or something like that?
I don't know if it's in a bad spot or whatnot. I'm not sure. It's just, it probably has a lot of supporting structures to hold it in place. Like, again, it's very vasculature, so. Okay, so the male reproductive system, testicles, epididymis, vasa differentia, seminal vesicles, prostate gland, and the penis. So to the side there, I wrote some things that you could run into as far as a problem. So in the testicles, there's something called a torsion, which typically happens with males as they go through puberty, which as the testicles laying there, it actually gets twisted. And it twists to where blood flow and things like that get occluded off. I've only seen it once, and that poor kid he wanted to just die. It hurt. And what they need to do is basically the doctor needs to pick the right way and get it spun back the right way. It's nothing we're going to attempt in the field. But if you guys go to a male going through puberty or just out of puberty and one of his testicles hurt really bad, that is an emergency. Because I think it's 3 hours if they don't get that spun and blood flow back to it, they could lose that testicle. Obviously, they're susceptible to trauma, but if you guys go to someone with severe pain, a 13-year-old, 14-year-old boy, then suspect that, and that is an emergency.
Is that a medical condition or a?
Yeah, it's just,
condition?
as they're growing stuff's, they were playing basketball, something bounced, moved the wrong way, but it's typically, it just happens. I mean, it could be a traumatic event, but like the one I recall, man, 20 years ago, that kid's probably 30 some years old now. I'm old. It was just an event that happened for him. Okay, the prostate gland, as males get older, it's kind of not a if, but when. Statistically, most males as they get older, 70s, 80s, 90s, are going to have prostate problems. It's going to get big, swell. It's going to include urinary flow. It's very susceptible to cancer. And then penis, again, you could have traumatic events, fights or whatnot that causes trauma there. Okay, female reproductive system, the ovaries, fallopian tubes, uterus, cervix, and the vagina. So remember that abdominal pain in a female of childbearing age is what until proven otherwise? It's an ectopic pregnancy until proven otherwise, because that is a bleeding and reproductive emergency. So unless they can definitively tell you, and even then, sometimes we don't believe them, because you can be on birth control and still get pregnant. You could have a menstrual cycle, a light one, and still be pregnant. So we still want to treat abdominal pain in a female as an emergency until proven otherwise. But here's some things that I threw in there. With ovaries, they could have cysts on them. That could be causing pain, intermittent pain. Hopefully your patient will know, but they might not. They might just have severe lower abdominal pain. Ovaries susceptible to cancer. If there's a cyst, they could rupture. Fallopian tubes, again, ectopic pregnancy. The uterus, there could be ruptures in a pregnancy, very, very rare. Uterine cancer, bleeding, cervix cancers, bleeding, and then vagina. Again, trauma, bleeding, a sexual assault, a foreign body, something like that, that could be causing trauma. So again, I pulled this off. So there's kind of the picture of the female reproductive system and some of the things that could be going on. Remember, some bleeding is normal. So menstrual cycles, maybe sometimes with complications with pregnancy, but this is where you're going to really just need to rely on your patient to try to tell you. Okay, urinary system, very, very important system. This is where a lot of the waste our body's excreting out goes out in our urine. So there are two kidneys. You only need one. A lot of people donate their kidneys, so ask about any surgical histories, things like that. Okay, this is in what's called the retroperitoneal space, so it's kind of back out of the way, out of everything. So it's kind of a lot of patients have kidney stones, renal calculi. Their pain might start way back here in their flank, like really high, and then kind of rotate around, go down into their groin. Be really suspicious of a kidney stone. With flank pain, that goes down and into their groin.
Is that the referral pain?
Not necessarily. We're going to talk about referred pain. I think it's just that kidney stone is making its way down the ureters and it's just hurting as it goes. But referred pain would be like it's in a completely different part of the body. So, and then again, blood flows high in the kidneys, so they're susceptible to trauma. Okay. Ureters join each kidney to the bladder. Bladder's connected to the pubic symphysis. Bladder kind of sits on men and women right here. So again, seatbelt injuries, open book, pelvic fractures, things like that could cause damage to the bladder and spill those contents. Typically, we should be having 1.5 to 2 liters of urine per day. So what happens with kidney stones is renal calculi, it could be genetic, it could be what we're eating, form in the kidney. And have we shown a microscopic picture of it looks like a asteroid with all kind of stalagmites on it, right? They're pretty gnarly looking. Well, and they can become pretty big too. So imagine that forming, and all of a sudden it hits the right spot in your kidney. Now it's going to start making its way down the ureters. So it's like literally ripping and tearing, getting stuck, doing whatever. As it's making its way down, trying to fall into the bladder. Once it gets into the bladder, typically the pain hopefully stops until, if it's big enough, until you go to try to pee it out, and then it can cause pain again. But most of the time the pain comes as that kidney stone is working its way down those ureters. Every once in a while, one's big enough, or there might be a couple of them that they get stuck. That again is a medical emergency, so you get to go try to get like ultrasounded blasted or something where they're got to break it up to get you to finish excreting it out. Almost every, I'll just use females as an example. Females that I've treated that have had kidney stones would much rather give birth than have kidney stones. The kidney stones are excruciating, and the guys have nothing to compare to as far as that, but they're very, very painful. So, and you will see people with kidney stones like they can't sit down. They're kind of just up. They're walking around. They hurt, and the best thing we can do for them is try to get them pain management so we can get them transported. But if not, you just be like, hey man, you got to grin it and let's get you in there. But they're very, very painful. So the abdominal cavity is lined by the peritoneum or perineum. So remember that all these organs, there's a lot of like surfactant, kind of slippery stuff, because we don't want this stuff bounding up. We don't want like sandpaper. So there's a lot of lubrication in there, so the stuff's moving around. But every once in a while, you could have like a peritonitis where there's an inflammation, whether it's viral, bacterial, whatnot, that takes away some of that, and it can cause pain. So every time they move, that stuff's moving around, it can be very painful because that surfactant, that slippery stuff is gone. So now those organs or whatnot are rubbing on each other, but that'd be impossible for us to tell. So foreign materials such as blood, pus, bile, remember everything is kind of supposed to stay where it's supposed to stay. Blood outside of the vascular system is very, very necrotic. It's very irritating to stuff like when it just touches it outside of its vascular system. So, you know, things like, say someone's perfed their bowel, they've had a colonoscopy, the doc nicked something, we didn't know it, and then 3 days later they come in with severe pain. Could be because that blood is irritating outside of that, you know, large or small intestine where it's not supposed to be. So acute abdomen refers to sudden onset of abdominal pain. Remember, acute means right now, like it's happening right now compared to chronic. So there's peritonitis, inflammation, peritoneum. Typically causes an ileus, which is where like the bowels stop working. There's a kind of a dead spot, and that peristalsis isn't happening. So like it says there, paralysis of the muscular contractions. And what happens is actually people start vomiting, but imagine if stuff's not going out one end, it's coming out the other. So you can have people who are actually kind of literally vomiting up their feces because if it gets so bad. And I've seen that just a couple times in my career, but I can account for that. I've seen that. So retained gas and feces. So, you know, as we're eating, you know, this might take a couple days. Someone doesn't realize, oh, I didn't have a bowel movement. Maybe the next day they had a small one. The next day they don't have one. And now all that stuff, but they're continuing to eat right at their normal volume. So all this stuff's building up. So gas and feces that's in there can become very, very painful. And they'll report actually of it moving around because as that gas kind of travels and it can actually spread that distension around.
Can nausea be a sign of that too?
Absolutely.
Because nausea is kind of like a precursor to vomiting, isn't it?
Yeah. Yeah. So upset stomach, nausea, absolutely. Okay, diverticulitis. So to differentiate these, a lot of people might have diverticulosis, which is the little inflamed pouches that form. Diverticulitis is when those pouches become inflamed, or when like fecal matter gets into them and irritates them or whatnot. So it's the diverticulitis is a progression of someone's diverticulosis. So someone might say, well, I have diverticulosis, but you go to them, they're having severe abdominal pain, they just ate food, it really hurts. They might have popped or inflamed one of their diverticulosis little inflamed sites. Cholecystitis, inflammation of the gallbladder. So how I was taught to look for gallbladder problems, so people are typically over 40, they're obese, and they've eaten fatty foods. They eat a lot of fatty foods. So if you go to someone that maybe matches those or not, like again, ask them what they ate. Oh man, I've had fried chicken and beer. They're having pain right here. They might have kicked off a cholecystitis or gallbladder issue. So again, good questions to ask on what they've been eating, what's their diet like. So there's two types of nerves, the parietal, visceral. And what you're going to find here, depending on what one of these nerves is irritated or is whatnot, is the type of pain that they're going to describe. Like Patrick mentioned, referred pain. We're going to go out into more detail. But what referred pain is you might have a problem down here in one of your organs, but your right or left shoulder is killing you as well. So it's in a completely different part of your body. That's what's called a referred pain. It's not radiating. Radiating would be it's kind of going from the same spot. Referred is in a completely different area, typically up in your shoulders. So here's one of the referred pains. It's not your book, but this is going to know. Okay, this is called Kerr's sign. It is one of the referred pains, which someone's laying down and they do a test where they raise your legs. If you have a spleen problem, I think it'll hurt up in your left shoulder. So they might do that test laying on the bed, or let's say you have someone laying on your gurney and they want to bring their legs up, or you move their, they want something under their knees. You raise their legs and all of a sudden they're, holy cow, man, my shoulders hurt. That might be a sign of a Kerr sign that they're having a spleen involvement. And you see why there. So those two nerves we just talked about, what happens is the body kind of gets confused because as those organs that are laying right in your diaphragm, they get irritated, they get injured, whatnot. They irritate your diaphragm, and then your diaphragm is connected right to that nerve that's going back up. And you can see there that it goes to your two shoulders, and the nerve can't tell the difference. So it's just gonna kind of say, oh man, I'm detecting pain everywhere. That's kind of what happens too when you have cardiac pain that goes to your left arm. It's kind of the same thing because that nerve that intervenes down in your heart is going by your left arm. So your body's kind of like that whole nerve hurts. So that's why you have that radiation in the left arm as well. It's because that whole nerve gets irritated and your body can't go, oh, it's just right there. It kind of describes it to your brain as the whole nerve. So again, here might be a gallbladder. So same thing, that nerve goes up. And now the gallbladder, it's hurting that, it's referring down to that guy's right arm. So that pain is being referred. Okay, ulcers. A lot of people have ulcers. They come on from genetics, from food, from stress. So little irritated parts. They could be in your stomach. They could be in your duodenum, your jejunum, throughout the entire system. And a lot of them heal, but a lot of them people kick off like certain types of food, maybe spicy food, something like that causes acid reflux or even bleeding. So, and what happens there, like it says, is that all of our organs have different layers, right? What happens is that excess of acid or whatever that irritant is basically eats away that inner lining and it's starting to irritate your duodenum or your stomach. It can cause bleeding. So when you guys think about bleeding with a GI bleed, this might come up later. When someone says, oh, when someone has a GI bleed, okay, that's anywhere from the mouth all the way through to the other end. So it's really important that you have an understanding of where they could be bleeding. So let's say someone complains of a rectal bleed, and you guys have heard of describing this dark tarry stool. Dark and tarry means there's blood in it. What do you think that tells you about where the bleed is at? It's high. It's high in the system because it's turned dark and tarry because it's gone through digestion. If it is bright red, it hasn't gone through a digestive process. So if someone's coughing up bright red blood, that's probably not coming from down low. It could be a Mallory-Weiss tear, esophageal tear, ulcers, things like that. Or if it's bright red blood at the rectum, it could be hemorrhoids or some type of bleed that's at the bottom. So dark tarry stool kind of alludes that it's gone through digestive process. Bright red blood tells you that it hasn't yet. So it's good to differentiate what type of people are describing, whatever kind of stools they're having or vomit. So gallstones. So remember the gallbladder, its job is trying to secrete stuff to help us digest fatty foods. And when we overwork it or we have genetic problems, we can build up stones. And sometimes they can be massive. And it can block the gallbladder. What happens is the gallstones go into the bile duct there and they start clogging it up. So the gallbladder is still producing these digestive enzymes and stuff to put into the duodenum, but it can't go anywhere. So it's starting to swell and it's causing pain. Yes, Patrick?
I'm sorry, slow to digest. Back on the blood, if somebody's vomiting blood, is there a cutoff in your system of where you vomit to versus it's going to pass down? Like, is the stomach a cutoff or is the stomach?
So I think.
Does that make sense?
Yeah. So
if we go and we need to diagnose somebody and they're vomiting blood, we can say, okay, it's from here up, not here down.
So the question is like, where could a cutoff be for bleeding either going up or down, right?
Right. Because I know you can have bleeding up and it can pass through.
Yeah.
But if it's vomiting, it's not down here.
Not necessarily, and where I think that would cut off would be is where the duodenum meets the stomach.
Okay.
Is there's a sphincter there.
Oh, okay.
So that's my guess would be if blood passes below that, in theory it shouldn't go back
Shouldn't go past the
unless the sphincter is bad or whatnot. Anything in the stomach could go up.
Yeah.
As far as vomit, the only other time, like we talked about, where you'll see people where they basically that sphincter can't hold on to the feces and stuff because of the small bowel obstruction, and it could work its way back up. But typically, I would think that the sphincter between the duodenum and the stomach would be a good breaking point.
So if they're vomiting, you can almost kind of pinpoint different things like a bleeding ulcer or whatever if they're vomiting.
So I would think so. So if someone's vomiting bright red blood, it's probably coming from the stomach or higher. I would think. Yeah, because I think if it's below that, it's going to work its way down.
Okay, thanks.
So what is one of the meds that you guys can give that you want to ask about this particular thing right here before you give it? Aspirin, very good. Ulcers, not necessarily a contraindication to it, but bleeding ulcers. Someone's like, yeah, I have bleeding ulcers. You probably want to make a phone call before you give them aspirin. Okay, pancreatitis. So inflammation of the pancreas is caused by obstructing gallstones, alcohol abuse, and other diseases. Okay, signs and symptoms include upper left and right quadrant pain, nausea, vomiting, abdominal distension, and then if it ruptures, if it becomes clogged up, you become sepsis. And then I put a note there. I've been fooled by this because it's so hard to tell, but what other thing could someone have? Upper belly pain, nausea, vomiting. What's another thing that they could be having?
Appendix rupture.
What's that?
Appendix rupture.
Yeah, so a rupture. Yeah, what else? What's another common complaint you guys might go to where someone has upper belly pain, nausea, vomiting, sweaty? What does it say there? An MI. So sometimes it's really hard to differentiate an MI versus pancreatitis. Is that, huh?
Everybody just got taken. Don't know, so I guess program.
And that would be a referred pain, right? If it's down to belly pain,
So not necessarily, because a lot of people present their MI across the top of their belly,
okay,
especially in elderly, like elderly females will present that way.
okay.
But just sometimes a pancreatitis, it looks enough like an MI that it's hard to tell the difference. And you might treat it as an MI because it's presenting that enough, which actually, like nitro and whatnot, which has vasodilation properties, sometimes can help this pain too. But sometimes it's really hard to tell. The biggest contributing factor I've seen to pancreatitis is alcohol abuse. Either whether it's an acute overdose of alcohol or just chronic, that they've gone into pancreatitis. Alcohol is a big contributing factor to that.
So, Don, you always hear about, I'm pickling my liver.
Yeah.
I mean, I'm assuming with pancreatitis and all that kind of stuff, cause of too much alcohol, I'm assuming that's just kind of the whole abdominal cavity affects the whole thing, right? I mean, because ultimately they're all kind of interconnected.
They are interconnected, and alcohol in excess is very, very detrimental to our bodies. And it does, like you said, your liver is working so hard to try to filter that. I guess I should point to the right spot on my body when I'm talking about the liver. Because your liver and pancreas and gallbladder is working overtime to try to filter all that. It can become enlarged, inflamed. But yeah, it affects everything, because you can see here the gallbladder is tied into the liver, to the stomach, the pancreas, all together, and you can mess them all up for sure.
Is this an acute alcohol overdose, or is this more of a chronic thing?
So what I've seen is that chronic alcoholism, but then someone might binge drink or something like that might kick it off.
Okay.
Yeah. Okay, appendicitis, inflammation or infection of the appendix. And like Casey just said, look at those same signs and symptoms: nausea, vomiting, you don't want to eat, fever, chills, rebound tenderness. So rebound tenderness is, we all know the appendix should be in the right lower quadrant, right? Rebound tenderness is when you press in, so you're doing your exam and it doesn't necessarily hurt, but it hurts when you let go. So that's a rebound tenderness. Another one for appendicitis is someone's laying there, put a little pressure on their right leg and have them try to lift their leg. And then because those muscles and everything that kind of go up in your abdomen, they could be inflamed. And if that causes pain, by right leg lifting against a little pressure, that could be signs of an appendicitis as well. Yeah.
Do you guys do the tap test at all? Where you now take their foot and take a block or something like this, resonates up, and
it's kind of, I think it's the same principle as, you're just manipulating that leg or whatnot. Yeah. So my thought on examining abdominal pain is that it already hurts. You've been called because your belly hurts, and yeah, maybe we want to try to differentiate what that is, but honestly, what you could be doing is going, oh man, my right lower belly hurts. Like, really? And then if you go start poking at it, you're just going to hurt them worse. Like, do you really need to know much more beyond that sometimes? It's good to do a secondary and abdominal exam, like in a trauma. You're looking for distension, stuff like that. But for me, if the medical complaint is I have pain in my belly, then you already know they have pain there. So what good does it do to go poking around and causing that to be irritated? If you feel you need to, which you might, just don't poke the place that hurts first, because then everything's going to hurt. So work your way over to it, because maybe you feel comfortable with the patient going, okay, I'm going to touch over here on your left side. I'm going to work my way across. And I've seen a lot of doctors do that. EMT class, they teach you to take your fingers like this, your two hands, and press on 4 quadrants. That's good for kind of a gross 1, 2, 3, 4. But I've seen a lot of doctors just take their hands and just walk their fingers across, which is a lot more sensitive, and you might be able to go, oh, that is starting to hurt right there, which might be more gentle and a better assessment tool rather than just pressing. What you're looking for with that pressing is you're looking for distension or bleeding probably in a trauma patient. So just be real careful with your physical abdominal assessments when that's the chief complaint, because you could really irritate someone because you're going to make them hurt worse. Gastrointestinal hemorrhage, again, it might be acute or chronic. Someone might have ulcers. Someone might have diverticulitis that's bleeding. Maybe there's a procedure. They had a colonoscopy. They had some other type of orthoscopic surgery where something got nicked, which is not uncommon. And then they have to come back in to get that artery or whatever it is fixed. Okay, inflammation of the esophagus. So lining becomes inflamed. Could be like genetic. A lot of times this happens with people with eating disorders. They throw up a lot because that's their anorexia or bulimia, whatever one. And all that acid that they continue to bring up, they're eating away the lining of their esophagus. Another one might be like acid reflux, where the sphincter at the bottom of the esophagus that's going into the stomach is failing, and then acids, all that really, really low pH, high acidity acid is creeping back up into their esophagus, and then it's eating away that esophageal lining. One thing you might see or people might complain about is like a funny taste in their mouth. Like, do you taste copper? Do you taste something that it might be coming up so high that they can actually taste that acid? A lot of people, it's a bad taste in their mouth. Again, the esophagus ends at your stomach right about here. So again, pain that's right here, what's the number one thing we're thinking it could be?
Tear.
Okay, tear, cardiovascular issue, before we start thinking about, oh, it just could be your esophagus. So we might go to something like that, and we're automatically thinking, oh, it's cardiac. But again, we're never going to be able to tell unless they're like coughing up blood or something like that. Esophageal varices. So very common, not common, but the common cause of esophageal varices, again, is alcoholism. What happens is due to alcoholism, kind of going back to what Jeff was talking about, is because of our liver being impacted, it's called portal hypertension. We're messing up all that vasculature. Well, that goes, and all of the vasculature around our esophagus becomes engorged and becomes where it can be ruptured easy. And then it actually can tear and start bleeding, which is a life-threatening event, because you could bleed a lot out of one of these tears, an esophageal varices tear.
We had a guy who still works with us on the fire crew that went untreated, just like cough and all that kind of junk, pneumonia basically, for like weeks on end, and just the coughing and constant. Anyway, he ended up tearing his esophagus and damn near died twice in the helicopter and in the ambulance, hauling him over to Wallowa, 9 units of blood later. I mean, he's still with us. Yeah. But like, yeah, it was pretty big. I mean, it was just from like untreated.
Because he's coughing so much, just
coughing so hard and so much, just untreated medical condition.
The one of these I know that I've seen, I think I was a student in Lafine. We got called across the street from the fire station, and this he's leaning in his car seat or his driver's seat, head against the steering wheel. The most god awful smell you could ever smell, but he's just blood is pouring out of his mouth, and he's been swallowing it from driving in. So he had the melena, the dark tarry stools that were coming out. He couldn't control it, and he was just sitting there with blood pouring out of his mouth because of one of these tears too. And I'm not sure if he made the helicopter ride from Lafine to Bend, which is probably a 15-minute flight. But like Jeff's saying, it's kind of a catastrophic bleed if one of these tears loose. Okay, Mallory-Weiss syndrome. And you could also get a Mallory-Weiss tear, which is kind of the same thing, where this supporting structure where these connect rip apart. So you could have active red bleeding. Gastroenteritis, okay, infection from bacterial, viral organs caused by non-infectious conditions. And then let's see. Yeah. So one thing that you need to be careful of with like a gastroenteritis or a symptom of diarrhea is this right here. Okay, this is a condition called C. diff. So Clostridium difficile infection. And it's pretty common, especially in the elderly. What happens is that someone starts taking antibiotics. The antibiotics kind of kill some of the good bugs in the stomach. And we always have C. diff in our body, but the C. diff takes over. The C. diff goes, oh, I don't have this other stuff keeping me in control. And then it takes over. So if you go to someone that their complaint is just uncontrollable diarrhea and maybe some vomiting, just in the back of your mind, it might be C. diff. This is something that you guys want to wear gowns, goggles. You want to try to do isolation precautions. If we have people in the hospital that develop this or get admitted for it, they are an isolation patient. You can't go into the room without wearing, gloves, gown, because you don't want to bring this home. So again, it's the main cause is uncontrollable diarrhea. What could uncontrollable diarrhea over the course of a couple of days? What could that cause? Dehydration, and then like electrolyte, particularly your potassium levels, could get out of whack. Yeah, but a big one's dehydration. So again, we don't know this without them testing it. It's a pretty quick test here in the hospital. But if you go to someone, just make sure you protect yourselves because it could be this.
And I was kind of reading in the book, they said that the hand sanitizers won't touch it.
No, we have to use, we have to strip the ambulance down and use the high grade, like vinegar, the stuff they're using to try to kill, the COVID and all that other stuff. We have to go get the big guns out and wipe the ambulance down with it. Yeah. So again, don't go to someone with C. diff or diarrhea, then go eat. Make sure you wash your hands and change your clothes and all that too. Real good idea, especially on stuff that originates from the gut. Guys, you don't want to bring it home to your families. So if you have to, like if you ever get a locker or what in your trunk of your car, like have sweatpants, have scrubs, have something to change into before you go home, because you don't want to give this stuff to your kids, especially C. diff. So, like my wife and I'll call her because she'll have the page and she'll just have my clothes out on the front porch. So if I go on a bad call and you see a naked guy out there, I'm not allowed to go to my house without changing clothes. But again, and like my kids, I get home, they want to come up and hug me and do all that, but and it sucks. You're like, no, I got to get to the shower or whatnot. But again, that's probably one of the worst things, at least for me in this job, is that I have the potential to bring that stuff home. Diverticulitis, we've already mentioned this, but it's where in those diverticulosis little pouches, they become inflamed. And then that's what's going to cause the pain. So fever, malaise, body aches, chills, it could lead into sepsis, hypotension, things like that. Hemorrhoids. So hemorrhoids are a condition at the bottom of the GI tract, right? It hasn't gone through digestion. So someone that has bright red bleeding or maybe bleeding when they wipe after a bowel movement is probably a hemorrhoid, or it's bleeding at the end of the GI tract because it hasn't gone through digestion. So that's where we've already talked about it, but my little highlight there, maybe the blood can give you a general idea of where the bleeding is.
You can have internal ones too, can't you?
Oh, sure, I think so.
Okay.
Yep. Okay, cystitis. So bladder infection, kidney infection, very, very common, especially in the elderly. It could be men or women. Like UTIs, because UTIs can wig someone out. It can really change their mentation. They could look like they're intoxicated. They could look like they have dementia. Those UTIs can be very, at least acutely detrimental to the elderly, especially females. They could be unconscious, not acting right, and it's all because of a UTI. So you want to ask, and this is one of the ones where we are using all of our senses for patient care, for patient assessment. where you can walk in and maybe in that undergarment they have, maybe they haven't been changed, something else has happened, and that urine smells very concentrated, or it smells foul or whatnot. Could be a UTI, and that could be what's explaining their very erratic behavior or them not acting right. And then again, hopefully just a little fluid and antibiotics, they'll be like a new person in a couple hours in the hospital. Okay, kidneys, again, they play a major role, eliminate waste, they help with our pH balances. The pH balance through the kidneys, the buffering systems, whatnot, take hours to days, but it does try to do it.
Are the kidneys the main buffering system, or I was reading there's another?
So there's three. So there's like your breathing out. There's it's like a carbonic. I can't think of it, but there's three systems that are all trying to maintain your pH balance. Us breathing is the quick one. We're trying to do that on a breath-to-breath basis. The kidney, it takes a little longer to do that, but it is one of the main ones of the pH balancing system. The problem is what happens so as our red blood cells break down, as our body's going through, its different processes, we have measurable amounts of waste that's in our blood. So it's a pretty simple blood test. It's actually one that we can do on the ambulance. And we can see how your kidneys are functioning based on where those waste products are in your blood. Like your blood, urea, nitrogen. So if that's getting elevated, we know that your kidneys aren't working right because they're not excreting stuff out. What do you think one of the main problems is that your kidneys aren't working right? What's one cause why your kidneys aren't getting rid of stuff? Dehydration. Yep, again, another reason why we need to stay hydrated. We gotta have plenty of fluid, plenty of blood that's not all thick and stuff to make those work right. So we need to make sure that we're staying hydrated. Again, another problem we can have is kidney stones. Again, very, very painful as they try to work their way down your ureters. Okay, acute kidney failure. So that is where, those levels are becoming elevated. Again, probably because of dehydration, maybe toxicology, something like that. But that's something we can fix. Maybe just with some extra fluid or some medicine, whatnot. But we have people who will go into chronic kidney failure, maybe due to diabetic, hypertension, things like that their kidneys aren't working right all the time, and we can't get them back. That whatever part of that kidney that's not working is dead and gone. Like it says there, it takes a while. And again, if it continues to happen, if we can't stop it, we need our kidneys. So either you go on dialysis or you need a kidney transplant. Okay, so female reproductive organs. So we all have the same parts, but then you throw in a female who has reproductive organs. That's a whole nother set of problems that could happen. That's other questions that you might need to ask to try to figure out what might be going on. So lower quadrant pain, like we've talked about, could be related to the ovaries, fallopian tubes, or uterus. Again, consider it an emergency, whether it's a reproductive emergency or life-threatening emergency, until proven otherwise. So, okay. This is one of the reasons why having a diverse crew, especially females in the ambulance, is extremely important. This could be sensitive, or comfort level for a patient, a female patient, and then to have two guys roll up and start asking very intimate, detailed questions about some of those things might make someone uncomfortable. However, I will say that females are, quite honestly, just with the medical stuff, they're stronger and way better than males, in my opinion, with what I've seen in my experience with patients. They go through annual exams, all that kind of stuff, so they're kind of used to those medical procedures. But again, we want to try to protect modesty and their comfort level as much as we can with these questions. But with that in mind, we still got to ask the questions. We still got to figure out what's going on. So your scenario is you go to a female of childbearing age, whatever it is, 14 to 54. okay, and they have lower quadrant abdominal pain. What are some questions that you might ask? What's that? Okay, so be careful how you ask that. So like, have you had sex, or?
Is there a chance, could you or may you possibly be pregnant?
Right, yeah. And then, but you need more detail on that, right? If they say no, you got to kind of quantify that. Like, why do they think they're not? So what are some responses that they could give why they don't think they're pregnant? Or they couldn't, there's no way they could be pregnant. Okay, so they have not, so they have not had sex with a male, okay, in a amount of time.
Their
Yeah.
parents are standing.
Please don't write down the patient said they were in your chart.
Their parent could be standing right there.
Yeah.
Right.
And that's a very good reason to not be.
So you guys all see Jeff there? He's got his arms crossed, he's a dad, and you come into his 15-year-old daughter. Could you be pregnant? He's gonna be probably pretty interested as a father in that response. So you wanna be real careful with how you ask that when you ask it.
So would that be a good place to have a female there where you can talk dad about sports and have her play the
Yeah, maybe if it's not he's the parent, if it looks like a good relationship, he has every right, to be there.
Yeah.
But dad might not like the answer. And then, so you just gotta be cognizant of that. I don't know if I have the right answer on how to deal with it. So-
Yeah, it's just HR, man, human resources. You just, yeah.
Yeah, so some of the stuff we've come up with is, okay, you say is there a chance you're pregnant? Okay, well, I'm either on my cycle, I just had my cycle. Could be a response, I'm on birth control. Again, birth control is not a 100% that they're not. Even a menstrual cycle, you could have a light one while you in the first couple months of being pregnant. So that's not their sexual activity, okay? Maybe they have other stuff. They have like some birth control lasts 3 to 5 years. Implants, or there could be intrauterine devices, things like that. On why they think they're not. So.
Well, there's the ones that say, well, I've had sex for 8 months.
Right.
I'm getting the stick. Here, try it.
Yeah. Yeah, because they're still probably gonna.
Because there's some people that have shown up. I'm not pregnant.
Yeah.
I'm just having this pain. And they're 8 months pregnant.
They're 8 months pregnant. Absolutely. Yep. Okay. So what other questions could you ask? You have a female of childbearing age with abdominal pain.
A last menstrual cycle.
Okay, so that's up on chat too. So their last menstrual cycle. Yep. If they're on it, okay, is there excessive pain? Is there excessive bleeding with it compared to normal? What else?
What about?
What was the last thing you had to eat?
There you go. Could have nothing to do with that.
Yeah.
Yeah. Could have something to do with something else.
Could have been one of these pieces of pizza.
Exactly. One too many pieces of piece of pizza.
What about antibiotic history? Because there's some people that say I'm on birth control, there's no way I can get pregnant.
Right.
But antibiotics can sometimes negate birth control.
So antibiotics can negate birth control, and antibiotics is one of the principal causes of C. diff as well. So absolutely, antibiotic use could be a contributing factor to those. What else?
History of ovarian cysts.
Okay, good. So cysts, ruptures, things like that. Good on chat, last bowel movement. Again, you might have ones that someone goes, oh, I've had bowel movements. Well, you might need to ask, well, can you describe them to me, or were they productive or whatnot? Because someone might go, actually, it was like rabbit pellets, because that might be just enough to sneak it by a small bowel obstruction, or it was real watery, loose. The other day, I had someone describe their bowel movement as impressive, which I wrote that in the chart. I don't know what that means. I just wrote, they said their bowel movement was impressive, which, good for them. Right, what else? What else could you ask?
Well, I've heard this, and I don't know if this is true, but can ovarian cysts or problems happen on certain fallopian tubes, so you're going to have it every other cycle? Or is that just allow us to know?
Oh, I wouldn't know.
Okay.
Yeah,
That's everything I want to know.
yeah, I'm not sure. But good. So those are some of the things you might ask. There'll be more. And think about that, because one of the things I'm going to do at the end of this is we're going to come up with lists of questions you guys could ask per complaint. So maybe some more will come up. So good. Another one online here is even just trauma. You know, did you get kicked in the stomach? The soccer ball hit you? Did you fall? So it might not be anything, again, related to the reproductive issues. Okay, so the aorta, again, the aorta goes all the way from the top of your heart, makes a turn, goes all the way down, splits, goes down your legs, turns into your femoral arteries. So I think Casey mentioned earlier, it could be an aneurysm. Okay, it could be those layers, those 3 layers of your arteries that's tearing apart, causing a big balloon or bubble there, and those could be painful. They say to look for like a mass. So you're looking at someone, you're looking for a palpating, pulsating mass, which might be that aneurysm that's big enough. The few AAAs I've had, I've never seen that. You know, I'm going more on blood pressures per arm, tearing pain, things like that. If you do see a palpable mass, don't go poking at it. Again, that's another reason why I'm really careful with my abdominal palpation, because I don't want to be the one to rupture that thing. But you might see it in a test where the sign of a AAA, or with an abdominal exam, you're looking for pulsating masses, and that's looking for this AAA here.
Lon, how would you, from your experience, I mean, those are, I mean, when that thing ruptures, you're done.
So my experience,
ultimately, so how are you going to package that patient if you're in a house with that patient? You got to get them to definitive care. How are you packaging that?
2 words: very gently.
Okay.
Very gently. I've heard stories of other students I went to school with. I might have said this in class, but they moved someone that had a AAA from their gurney to the bed. That movement, the guy died a couple minutes later laying in the bed. I've heard of surgeons trying to get in to get to these. It ruptures in front of the surgeon. The surgeon just throws this, like there's nothing that can be done if these rupture. So they're very catastrophic. Now they can find them and get to them in time. They can stent them or secure them or things like that. But if they rupture acutely, then they're life-threatening, if not a catastrophic event. And then, like it says there, pneumonia can cause ileuses and abdominal pain. Kind of like what you were saying earlier, that coughing, that irritation. So pneumonia can be very detrimental, especially to the elderly. Okay, hernias. So hernias are where, like, your bowel or something kind of squeaks into another part of your body where it's not supposed to be. Might be down into your scrotum. It might come out through your belly button, where those layers, those muscles have come apart, and now things are basically going into other parts of your body where they're not supposed to go. So you guys, the medical emergency with a herniation, I couldn't think of the word earlier, but it's strangulation. So think about what you think of strangulation, where you're cutting off air and blood supply. You have that part that's sticking out, and that abdominal muscle or whatnot now clamps down around it, and now it's not getting blood flow. So everything that's sticking out there, and maybe even past it, depending if it's including blood flow past that going down, is strangulated. It's going to become necrotic, ischemic, and it could die, which is a medical emergency. So the problem with hernias is that whatever's sticking out could strangulate. Okay, so a lot of times the doctors will take this and push it back in, but it's where they can't do that, or the patient, sometimes even patients get them enough, they'll try to push them back in. You'll go to a lot, you guys can sometimes see hernias through like a t-shirt, like a belly button, or you can just see this big mass on their belly. And especially like if they move, they flex those abdominal muscles, you can sometimes see a hernia through their clothes. You just ask them, do you have a hernia? They're like, oh yeah. So there's something that you can see on an assessment in the field. Again, but if you see that discoloration and it's something new, they're like, I don't know what the heck's this coming out of me, and it's turning colors or whatnot, they're probably at a risk for strangulation. That's a medical emergency. You got to get into surgery. So there's an example down there, almost the lower abdomen there. The abdominal muscles became weak. and now the inguinal hernia is sticking out. If those muscles, that abdominal muscle starts squeezing up against it, it's going to strangulate what's sticking out there. Okay, your size of obviously scene safety. So you get called to someone with a complaint of abdominal pain. What are the scene safety like? What could be a danger to you there with abdominal pain?
I don't know if it's going to be probably more of a bloodborne pathogen.
Yeah.
Poop scene.
Right, it could be. Yeah, so you could have a bloodborne pathogen. You could have another pathogen. You know, the C. diff, pneumonia, something like that you're walking into. That's dangerous. Good. So what else?
Well, if alcoholism is the main cause, they could be looped and have guns or anything else.
Yeah, so if it's a toxicology issue, if it's an ETOH alcohol issue, absolutely. Again, that person with the UTI who's flailing around, this little 110-pound, 70-year-old lady that's kicking the crap out of you because she has a UTI and is not reasonable, whatnot. Is it a poisoning issue? Is it a trauma? Did they just get kicked? Is it domestic violence? Because boyfriend just found out girlfriend's pregnant and he decides to put a size 11 into her belly, which sometimes happens. So again, we always need to be watching out for our scene safety. Is it a trauma? Was it a baseball bat? Was it a steering wheel? Did it even happen today? Was it something that happened the day before? They did not seek medical care. So you might need to ask, has anything happened in the last couple of days? Characteristic odor. You guys, it's never a good odor. So
Chances are you're gonna smell it before you walk through the door
Yeah.
of the house, if it's in the house.
that's where you know who the new guy is based on where they're at when you're carrying the patient. So your primary assessment, airway and breathing. Again, airway and breathing could be compromised. One of the things that could cause this is pneumonia. Is it an acid reflux? Is it something that's causing them kind of to cough and choke that you need to make sure you know what you're dealing with before you move on? Even though they're hurting down here, airway, breathing, circulation first. Okay. Have they vomited? Are there black tarry stools? Check pulses in both arms. Why are we doing that? Looking for what? What's that?
AAA.
Yeah, an aneurysm. Yeah, primarily one that's coming off the top of the heart. And then for us guys, we're always going to assume that these are a medical emergency because we just don't know what's going on. So some other, looking at chat here, some other stuff these guys put, like is it a gunshot? Again, is it that we didn't mention? Is there an access issue? You know, was it a fall? Was it a hiker that drank some mountain water and now they have giardia or cryptosporidium or something like that, that they have such unbearable cramping that they can't walk now? So what's access? The thought here is dangerous terrain or access, things like that. So and that's another good thing too. You know, ask about abdominal pain. So you drink water. Where did your water come from? Does it come from a well? Do you drink from a stream? Things like that. That they could get these microorganisms in their belly. Okay, your sample. So have they been nauseous? Have they been vomiting? Again, what color is, what's the vomit like? If they haven't eaten anything, like lots of times I just describe dry heaves, unproductive. They're cramped up, but there's nothing in there left to throw up. And sometimes people just get out this frothy, foamy, white or green bile or stuff. That's all that's in their belly because they've been vomiting and they can't eat. So what's another thing that vomiting, active vomiting, is going to affect? What I'm thinking you guys might not get, but think about people's medicine. Okay, did they take their morning meds and then they threw up within 20 minutes? Those meds might not have been taking effect. So again, if someone goes, "Well, did you take your morning meds?" "Yeah, I did." "Well, when did you start vomiting?" Kind of right after I took my meds." They might not have their blood pressure med on board or their seizure med because they've thrown it up. So something to think about. Okay, change in bowel habits, urination. We should ask that on every patient. And I just kind of generically ask it, how have your bowel and bladder movements been? And then if they tell you something that's been abnormal, you might need to ask more questions. What could pain with urination be?
Kidney stones.
Kidney stones, absolutely. What else?
UTI.
UTI,
Gallstones.
okay. Maybe an STD. Yep. Okay, significant weight loss. So someone's lost 30 pounds over the course of 30 days. Is that normal? I'd like it to be normal. For me, it's not. But what could cause significant weight loss?
Fluid loss.
Fluid loss, yep. Maybe they're diabetic, or their diabetic issues changing, and now they're just peeing all the time. They're not keeping up with their fluid intake. What else could cause weight loss? Especially with what we're talking about.
Diarrhea.
Yep. So a lot of people have aversion to doctors, right? So they've been having belly pain. Every time they eat, man, they throw up or it hurts. So now they're not eating, but they haven't gone to the doctor because that diverticulitis, diverticulosis, that whatever's going on is undiagnosed. But they haven't ate for a month because every time they eat, it hurts. So now they've got to where they don't eat. So weight loss might be a clue that they have an abdominal thing going on. Maybe a cancer, maybe their chemo, maybe something like that their body's reacting to. Stress. I've seen people just because of stress, they don't eat. And they have a significant weight loss. Okay, significant belching or flatulence. Okay, it could be a small bowel obstruction. Could just be the food they ate. I won't say any Mexican restaurant names locally, but maybe they went to one of those places. Not to offend, I eat there. Okay, it could be just something they ate, but it could be other medical stuff going on. Pain, man, my chest hurts and my belly. Well, what came first? Which one is it? Is it two things? We don't know.
Seems that, I don't know if this is a weird question or not. Same as the vomiting, is there a cutoff for belching and flatulence? Is it that duodenum?
It's probably the same spot. Belching is going to come from the stomach. Yeah, and flatulence will come from below that, probably that sphincter. But again, let's say someone hasn't gone to the bathroom, hasn't had a productive bowel movement in 5 days. When they belch and it smells like feces, they might have feces backing up. Okay, your secondary assessment, your physical exam. Okay, a normal abdomen is soft and not tender. Okay, pain, tenderness, signs of an acute abdomen. You want to expose and look at it. And again, if you feel you need to palpate really gently. Again, it doesn't look at when someone goes, I have belly pain, and you literally start poking at it. Really, right here? Does it hurt right here? Because they're like, yeah, idiot, I just told you that's where it hurts. So you want to be real careful with your palpation. If you feel you need to palpate, work your way towards the pain. Because if you set off that painful spot, the rest of your exam is going to be not as accurate. So you're palpating the abdomen. What kind of stuff are you looking for?
Rigidity.
Rigidity, what could rigidity be?
Action.
Yep, okay, could be, 4 or 5, 6 days of stool sitting there. Okay, what else?
Blood.
What?
Blood.
Blood, yep, blood.
Discoloration.
Discoloration, bruising, exactly. What else?
Distension.
Distension, yep, perfect. And then 2, you are trying to elicit to see if something hurts. Like, let's say you're just doing a trauma exam and they have a broken shoulder and that's all they're concentrating on. You're doing your exam, and you touch there and like, oh man, that actually did hurt. So you're actually looking to see if your palpation elicits a pain response. Yes?
This is weird, I don't know if it's associated with it, but what about petechiae? Is that?
So you mean like ruptures in the eye or?
Is that what it is? I thought it was just ruptured in the skin, petechiae.
So I'll have to Google it, but I thought petechiae was ruptures of the vessels in the eye.
Okay, never mind. You're probably right.
Or petechiae might just be ruptures of small vessels. I'm not sure. We'll look at it. So another thing to look at is look for bruising. Some people take shots at home, insulin, or like something called Lovenox, which is a blood thinner, and they might do their own shots. So you might see like telltale, like a pattern of bruising, and that might be from them taking their own shots. Another one here is rebound tenderness, like we've talked about. So if you press on, like, that doesn't hurt too bad, but then you let go, and that causes more pain. You want to see, like, if you press on the left side, does it hurt on the right? That might be a sign of appendicitis as well. Kind of that pain that's transmitting over to the other side.
Would you ask certain types of medications that slow down the bowel activity too?
Yeah, so there's some drugs called like protonics and octreotide, which are designed to slow down some of those functions. Maybe if someone just has constant diarrhea, they have a GI bleed, they have ulcers, they're trying to slow that process down. They might be on like a Prilosec or another H blocker, I think Retinidine, something like that they're trying to slow down those H1 or H2 receptors. They're trying to slow that stuff down. So that's a great question to ask if they're on those abdominal meds. And then vital signs. What are your signs of shock?
Cool clammy skin.
Cool clammy skin. Someone else. Tachycardia. Okay.
Rapid breathing.
Rapid breathing. Yeah. What's a late sign? But it could be a sign. Blood pressure. Yeah, blood pressure is a late sign. Oh, here's a real good comment. You guys know what guarding is? What's guarding? Someone's like, don't touch me there. They're taking their hands, they're in the fetal position, they're laying on their side, or they're taking and they are trying to protect. They're guarding against where that's hurting. It might be the arm, but a lot of times they're sitting there and they're curled up because they're trying to protect that abdomen from any more pain and whatnot. And that's a good thing to write to. Medic one arrives, you walk into a 12-year-old female laying on her side, fetal position, guarding her abdomen. I mean, doesn't that paint a pretty good picture of what you just walked into? Okay, your reassessment. Unstable patients get reassessed how often? 5 minutes, good. A lot of times, like we just talked about, you guys, a lot of times I let people lay on their side. We try not to let people lay on their belly. Almost no one wants to lay on their belly. But a lot of times people want to lay on their side and kind of curl up because it helps with pain and whatnot. And as long as you can get to an arm for blood pressures and stuff, most of the time I let them because that's just naturally how they want to be. Kind of hard to buckle them up, do the best you can. But a lot of times I'll let people lay on their side just for their own position of comfort. Okay. It's hard for us to find the cause and we certainly can't treat it. Again, maybe as a medic, we might help with symptoms with pain or fluid. But other than that, like if someone has appendicitis, if someone has diverticulitis or whatnot, there's nothing we can do for that in the field. Even a poisoning, if it's in their belly, if it's over 69 minutes, there's nothing that we can give, with a few exceptions. Treat for shock even if the obvious signs are not apparent. You just kind of have that index of suspicion. You're like, man, you just rolled out of your car, you got ejected, you got hit with a baseball bat, you're doing pretty good. Guys, our goal is always try to be ahead of that because we're already always behind, right? Because we're not there when it happens. We roll in 10, 15, 30 minutes later, like we're behind whatever's going on. We need to rapidly try to get ahead of it. The last line there with a GI complaint is make sure we do a good job cleaning. We might not be told that it's C. diff. We might be told it's another infectious disease process. So gown up and then make sure you clean your equipment really well. And think about everything. We'll go through ambulance operations some night, but think about all the stuff that you touch. Your HEAR radio, the handles up above, all the parts of the gurney, your bags, your blood pressure cuffs, the little finger probes, all of those things that have been touched, we got to think about. Pull back out, wipe it down really good and let it air dry. So, the cupboard, we're flipping through stuff, trying to get to that nasal cannula that's behind a couple non-rebreathers. Like we just touched all that stuff. So we need to try to do a good job of wiping it back down. Okay, dialysis. Again, the dialysis center here is in LeGrand. We don't have one here, but a lot of people do it at home. We've been to several people, like in Joseph, that would do their own home dialysis. There's a couple of different ways to do it. The ones that do it at home do it peritoneal dialysis. So they have a port and they basically put in some fluid that tries to draw out the toxins that your kidneys would, and then it pumps it back out. And they do that a couple times a day. And they can do it right there at home. Most of the time, either that patient or their family member is going to be the expert in that machine. You just got to kind of let them, you're just there to assist them or help them. The ones I've seen, like we go to in Joseph, is it would cause the guy to have occasional syncopal episodes. Those shifting of all the electrolytes and stuff, and he wouldn't feel good and he had to lay down. And one time the lady was like, listen, he's at a critical point of his cycle, the fluid's in him. Like you guys will wait here and he will not be, I'll let you transport him. This was the wife called the shots in this house. He will go, we'll go, but you will not do it until this cycle finishes. And we're like, cool. Because we don't want to interrupt that. That stuff sits in there, it's going to continue to draw stuff out of his blood. So you might need to sit there and wait, which we ran into that one time.
Brandon moving him from the floor back up to the
Yeah.
bed, we had to wait.
Yeah, she did not want anything done, and she was calling the shots and okie dokie. Some services transport patients to and from dialysis centers. We don't do that here. Some agencies, like if they're at acute care in LeGrand, might take them over their appointment and back, but we don't typically offer that service here. Okay, and again, it functions kind of like the kidney. So this fluid it's putting in is like a high concentration, so it's drawing out those toxins, and then it gets pumped back out. And some people do it 2, 3, 4 times a day, or cycles once a day, whatever it is. But think about, you guys, this is literally like it was gallons of fluid, every time going in and out, liters and liters. So all those fluid shifts and everything could cause electrolyte imbalances, muscle cramps, nausea, vomiting. Look for infection, look for maybe that port became waters, maybe he stood up, got pulled out of his belly. So lots of problems can come from this. Okay, again, emergency care, ABCs, provide high flow oxygen, treat for shock. If they go into pulmonary edema, so their sats are low, they can't breathe, you guys are listening to their lungs, there's those wails or crackles, then maybe if they can tolerate it, sit them up, try to get that fluid to kind of go down. Don't lay them flat because then all that fluid is now across all their lung fields. And then transport quickly. So we're almost to the end of this, that's why we're kind of powering through. So here's the 2 types of dialysis. There's hemodialysis, which they might do at the centers, which they plug into a machine and they run their blood through basically like a kidney machine, a dialysis machine that's going to filter the blood. They have what's called a fistula, where they actually combine in their arm, they combine an artery and a vein. Sometimes they fail, sometimes they take a long time, several months, I think 3 months, for those to kind of hook up to each other, to grow together, so they can use this as a spot for dialysis. A good idea, whenever you guys check blood pressures, ask someone, is it okay for me to do a blood pressure on this arm? For this reason right here, maybe they're not dialysis anymore, but they still got that fistula there. And if you go to press on that, you could rupture it. Maybe they've had a mastectomy, they've had nodes removed, and they don't want stuff done at that arm. So a good idea is, hey, my name's Casey and I'm an EMT, I'm gonna do a blood pressure, is this arm okay to do one on? A lot of people have a preference, what arm they want a blood pressure done on. The other one there you can see is just a tube that goes into their abdomen. It fills their abdomen with fluid. That fluid draws in the toxins and all the byproducts, and then it's pumped back out. These are the ones you guys are going to see in the field if you do have a dialysis emergency. But someone might have hemodialysis. They travel to LeGrand 3 times a week, but maybe they have a fistula went bad. They have one of these syncopal episodes. So you want to ask them about their dialysis, how their treatment go, did anything go wrong, were they able to complete it? So they're up in the one is the ones that people do at home. So you can see there, those bags, I don't know what they're at least, 6, 8 liters or a couple gallons that they put in at a time, rotate out, put a new bag on, do it again. and you just sit there and do it. It takes a couple hours, at least the experience I've had. The other one there, that one's pretty pronounced, but that's kind of a fistula there. So you can see it's to the surface. That's where they access the dialysis, put the needle in. But again, we don't want to be the guy that puts the blood pressure cuff on, pump it up and blow that thing, because it takes a long time for them to mature and to connect together. We don't want to be the one to pop that. So make sure that you don't see that, and that you do your blood pressures on the other arm. Okay. So we're at the end of the curriculum. I mean, you guys okay to roll for 20 more minutes, or do you guys want a break? So now what I want to do is, especially with abdominal, with GI, the biggest complaint is going to be pain, and you have to do a really good assessment. However, dealing with pain on people is really difficult to try to get them to tell you what their pain is at. Like, you guys have probably had pain somewhere before, and to stop and think about how to describe that, it can be really difficult. Well, is that a 2? I can feel it. Does it really hurt? Is it scary hurt? Like I can't breathe, like I can't function? And then what people communicate back to you, people just don't, and we're putting them on the spot. So like, hey, can you put a number on this? More often than not, people are like, their legs are crossed, they're on their phone Instagramming, like, oh, it's an 8. No, it's not. That is not. An 8 there is like you can't do basic functions. Like, you are hurting so bad, you wouldn't be able to operate your phone. But that's just what people tell you, and that's hard to get around sometimes with our charting and whatnot. So this is a good tool to try to use. Some people who are cognitively impaired, like the elderly, there's like, I don't know, like I can't. People have asked me that before. I don't know, I can't do that. So what I just typically document is subjectively what you find. Like, what are some things you're going to see if someone's in pain? Like, they don't have to tell you anything. What are you going to see? Grimacing. So grimacing is like that. You can see it in their face. Like, they go to move and they're, that's a great thing. What else?
Their body like kind of tenses up.
Yeah. So maybe guarding. You can see them like wince, or some other type of protective, or that it spasmed on them really quickly. Good. What else? Well, let me back up. Like, how do you describe that? How do you write when patient stood up from their chair? You notice that twinge. Like that can be hard to try to describe, but you got to try to describe it, because that's a really good way to show that your patient was in pain, to quantify why you were there and what they needed from you. What else are you going to see that someone's in pain? That they don't have to tell you anything. You just look and go, man, you're in pain.
Facial expressions.
Facial expressions, okay. Sweating,
Red in the face,
okay.
skin color.
Skin color, trauma. So you see something like, oh, dude, that knife in your chest probably really hurts. Okay. Tears, crying, and then tachycardia, elevated blood pressure, sympathetic responses to the pain. So like, if you're sitting there, you're on the ground, like, hey, how much pain are you in? Someone's like, oh, I'm in an 8, but their pulse is 60, they're not in pain. Pain will elicit an elevated heart rate.
So you said something, I'm getting curious about. You said pain activates the sympathetic nervous system?
Well, it's just a response, like you're in pain, so maybe it doesn't activate that system, but you're kind of like, your body's like, I'm in pain, so your heart rate's going to go up. It doesn't know why, so it's trying to prepare.
The reason I asked, I always had a hard time between what does one, what does the other, and pinpoint it, and maybe
You mean like parasympathetic versus sympathetic,
yeah.
or?
Yeah.
So just think about parasympathetic.
And what the sympathetic nervous system does, like you said, increases blood pressure, increases pulse rate.
So the simplest way I can describe that is parasympathetic is rest and digest. Okay, parasympathetic rest. Sympathetic is fight or flight, the saber-tooth tiger kind of response.
Right.
So if you're in pain, like what caused you to be in pain? Were you attacked? Were you whatever? So your body's just reacting to that.
Your autonomic nervous system is kind of activated.
Exactly. And there's some people that there's a couple really good comments on chat here about this, but there's some people that when they get really septic, when they get really sick with an infection, the only thing holding them together is that little bit of sympathetic response. And we could, as a paramedic, I might go to intubate them and paralyze them, and their body just goes, I'm out, I'm done. So we have to be really careful when we take away some of those mechanisms with people who are really septic, that last bit of sympathetic tone, because we could kill that altogether with drugs and whatnot. So that sympathetic tone, I think, is associated with that, kind of that hemodynamics and pain response. Some other stuff here is, so they shift a lot, so they cannot get comfortable. They're on your gurney moving. Can I lay to my right side? Can I lay to my left? Can you put something under my knees? Can you put it back down? Holding your breath, letting out real slow. We've all done that. Just focused on the pain. So this is a really interesting part. It's something called distracting pain. So you have to be cognizant of this with your patients, because if someone's distracted by pain, like they might just be a dislocated thumb, but they might not notice that their legs turned all the way backwards because they're concentrating on, they're like, oh my God, my thumb. In this situation, this pain here, they don't recognize other stuff that's going on. Like we cannot clear, if someone even has like a stubbed thumb or stubbed toe, and they're like, man, my toe hurts, it's really bothering me. Like they get a collar and everything because of distracting pain. We might not trust them that they can't tell that their neck's not hurting. So someone might be really distracted by that pain, or they're focused on it. Might be a clue that they are in pain. And then Emily has here like not wanting to move or sit in a certain way, which again could be real common with kidney stones. Someone's like, I cannot sit down. So when I sit down and it applies pressure, it hurts. They might want to lay to one side or the other. Let them assume their position of comfort.
Wouldn't be able to speak to you.
Right. Just because they're hurting so bad. Yep. You guys don't, this is out of this curriculum. I've seen this in previous curriculums. I had to know these going through basic and paramedic school, but are these terms in your book? Have you guys seen these terms? Somatic versus visceral pain? So it should be, it could be, like I said, I've seen it in other curriculums and I had to memorize going through school. But there's kind of two types of pain. So somatic is like it hurts right here. It's a sharp pain that hurts right there. I can point to it. Visceral pain, like it's out of those hollow organs, and it might be diffuse pain. It kind of hurts everywhere. It's hard to describe, but it's kind of based on what of those organs might be hurting. So someone might go, man, my liver hurts right there, versus a diverticulosis or litis that they're like, man, my kind of whole gut hurts, and I can't really describe it. So again, maybe you guys want to write down just somatic versus visceral pain and look it up later. Again, it wouldn't surprise me if you saw it again. This used to be kind of a common way to differentiate pain. And some of the other comments from the people in Chatland are that they did have to know this stuff for their basic class. Like I said, I was kind of, and I think I talked to Robert earlier too, and we were kind of surprised that it wasn't in your PowerPoint slide, these two types of pain, kind of common things for you to know.
Hey, Don, page 708 under abdominal pain.
Okay, is it there?
Yeah.
Okay, good. So really what you have to remember is visceral might be kind of a generalized pain, somatic is very pinpoint. That should get you through a test question or whatnot, if you can at least remember that. Okay. So I Googled synonyms for pain. And this kind of cool list came up. Some of them I've heard a lot, some of them I haven't heard that much, at least on the English. But you guys, if you go, hey, remember we want to try to do open-ended questions. Can you describe your pain to me? Some people can't, and you might need to try to lead them on. Well, is it this? The common ones, like what are some common ways you guys could imagine that you could describe pain? Most of them are probably on this list, maybe some not. Like what's one way you could describe pain or a painful sensation?
Radiating.
Okay, radiates. Does it go somewhere from you know, from another central point. What else?
Dull, sharp.
Dull, sharp, what?
Pulsating.
Tearing, pulsating. Is it intermittent? It's intense, it's a pressure. Sometimes, a lot of times on chest pain, like, oh, you have a chest pain? Well, I'm not gonna call it a pain. It's more of a pressure or discomfort. And a lot of people don't want to admit it's pain, or they can't describe it as just pain, but they'll use pressure or discomfort. Which again is hard, because how do you put discomfort on a 0 to 10 scale? Sometimes it's hard for people to do that. What else? What other words could you use to describe pain that your patient might use to describe pain? Throbbing. We've all banged our thumb, right? Or all had something that's throbbing. A cold injury can throb. What else?
So up there it has itchy. So what, how would it, like, what would be an example, like, how would you describe that? Like, how would the patient use that?
Itchy. So like an allergic reaction or hives or something like that, like a severe, like I said, I haven't seen that with necessarily trauma, but when you're sitting there, and I've seen people with hives so bad, they want to scratch their skin off and stuff, so.
Like frostbite be that way too.
It could be, where it's like tingling, like, man,
Start to get
you're sitting there wanting to apply pressure to it or something, because it's like that pins and needles. What else?
Going up there, I'm seeing Dawn is nagging.
Nagging. Like it's kind of there. It's more of an annoyance. Doesn't hurt real bad, but numb. Yeah. It hurts so bad that it doesn't hurt. It hurts that bad. Or maybe there's one spot that, like, because of damage, like a burn, like a 3rd-degree burn won't hurt there, but it'll hurt around it. So that one part might be numb. Frostbite, things like that. A burn again could cause that. And some people might say, listen, man, I can't describe it. I can't, but it's unbearable, or it's intense, or I can't take the pain. To be honest with you, on the ambulance, I've really seen very little of that, but when you see it, you know. When you walk into the guy who's in his bathroom, holding himself up off the floor because his back just went out, and any pressure is absolutely excruciating, like those are the ones you walk in and you're like, dude, I believe you. When they're pale, they're sweaty. And then you'll see the ones where they're like, oh, I'm a 7, and they're like Facebooking, and their feet are crossed, and their pulse is 60. So
Like that lady up in Joseph we had a couple weeks ago. She was laying there and it like just spasm, and she'd be screaming. Pain.
Yep. Oh, on the floor? Yeah. Which she thought we were all wonderful, by the way.
Good.
Yes. Yeah, but so some of these, like, we try to ask open-ended questions, but you might need to try to lead someone when they can't answer it. Another one that comes up a lot is just aches. It's an achy feeling, or, you know, throbbing is really common too, like Casey said. So a lot of times it's intermittent, like there's one word they're called bolts, like, man, it's okay, and all of a sudden it's like spasm. It'll be like this intense pain for a second, it'll go away. Maybe nerve involvement or something like that.
There's something about abdominal pain too, because I've had a lot of injuries, broken bones and everything, and it wasn't that bad. It hurt. I get a stomach ache or get a stomach thing going on, and I tell you what, you could kill me now.
Yeah.
And I would be happy.
Yeah. Well, and I've like worked with people who have had like their diverticulitis, like on shift, turn into their diverticulosis, and they crumple to the floor. They're in the fetal position, and they are in agonizing pain. So. Okay, just the last couple minutes here. That's the end of the curriculum, but just you guys will find that when you talk to people, like getting a good assessment of their pain is really difficult. What I'd like everyone to do now is take out a piece of paper. So what we're going to do now for the next 15 minutes only is, and if you guys on chat land, if you can hear me, go ahead and write some of these too. I'm going to throw out a scenario, and I want you to at least just verbalize questions that you might ask, and I want everyone to write them down. And then someone might ask a good question, and then maybe there's a follow-up question. Because you will need to do this for your obviously in real life, but like for your medical assessment, there's certain categories that you'll go down So like if you have an OBGYN, you get points for every question that you ask. So if you sit there and you ask 8 or 10 awesome questions, it's just another thing that proctor knows that you're trying to get a good assessment on. Okay, so your first scenario is you have someone, you're called to someone with right leg pain. What are some questions? Right leg pain.
Are you on thrombolytics?
Good. So do you have a history of blood clots? Are you on a blood thinner? Perfect. So now you assess that leg, and one leg is swollen, it's red, and it's hot to the touch. That could be a sign of what Patrick just talked about, is they could have like a bad DVT or an arterial thrombosis, that now they have blood backing up. You know, back here, the popliteal artery, maybe behind the knee, they just had surgery. Blood clots in the legs are really common after like hip and leg surgeries. So that's perfect. Have you had any recent surgeries? Is there any concern for blood clots? Great. What else?
Do you have a history of AFib? That might cause it.
Yeah. Yeah. Do you have AFib? And then if someone goes, yes, I am on whatever medication, I am on a blood thinner, what should be your next question?
Have you taken it?
Are you compliant with it? Yeah. Do you take your meds like you're supposed to? Exactly. What else? You go to someone with right leg pain.
Are you possibly the driver of that flip four-wheeler?
Exactly. So trauma. Have you had any recent trauma? Okay. Anything else? Okay. Here's some other ones. Has this ever happened before? If it has, what did they come up with?
When did this start?
When did it start? What were you doing when it started? Are you a 42-year-old man trying to do backflips on the trampoline with your 7-year-old son because you still think you can do it, and as Mother Nature proves, you probably can't do it?
Does this happen to you, Don?
I'm not going to decline or confirm that.
Confirmed or denied.
Yep. Actually, trampolines are illegal in my house. My kids have a lot of dangerous stuff, but I'm not going to actively give them something to break their neck.
Almost happened to me once.
Danger rating.
What's that?
Danger rating.
My kids run around with knives and hatchets and machetes, but for some reason a trampoline's a dangerous obstacle. So I'm not going to do that.
Well, you add the trampoline to the knife hatchets.
Right, which my kids would. They'd be out there in football, like it's freaking Thunderdome or something.
Family history?
Family history, okay.
What part of the leg?
What part of the leg? Yeah, big difference between your ankle and your, thigh or whatnot. Some other stuff on here. When did it start? One thing is, hey, did it come on suddenly? Is it a 10 out of 10 right now? Or did it start as a 1, go to a 2, go to a 4, and kind of progress its way up? Was it a 7? After some ibuprofen, it's back to a 2, now it's back up again. All kind of, intermittent or waxing and waning pain. Okay, so your next scenario, you go to a 22-year-old female, you go to a nice house, there's a caring husband or whatnot there. She says she's about 7 months pregnant and then is having abdominal pain. We haven't gone into this chapter yet, but I think it'd be good to start thinking about your questions here. OBGYN is one of the things you could be testing on in your medical scenario.
When did it start?
When did it start?
Did your water break?
Yeah. Is there bleeding? Bleeding, 3rd trimester bleeding is not normal.
Are you in the care of a OB?
Yeah.
Are you
So-
seeing an OB?
Yeah, or are you, looking just for a midwife or something like that? Do they expect any complications?
Is there any drugs or caffeine or anything that can cause either a pre-pregnancy or phantom signs or something?
I believe so. I don't know specifically, but I imagine like stimulants,
Yeah.
like cocaine, methamphetamines, things like that could cause stuff like that. Absolutely. So illicit drugs, alcohol use, normal drugs. Some other stuff on here, trauma. One thing that pregnant females run into, especially later pregnancy, their joints become looser. They have this kind of a lot of weight maybe in front of them. They could lose their balance. So is there any trauma? Have you fallen? Have you slipped? Has anyone here ever slipped and like caught themselves? And the motion of catching yourself is worse if you were to just fallen. Okay. Okay, bleeding. Is there any contractions? What's that?
Catching yourself
Yeah.
falling, blown out knees.
Exactly. So again, we'll get into this later, but you know, one big question is this your first kid? How many times you've been pregnant? How many live births have you had? Because if you go to someone, let's say you're up at the lake, the water's broke and it's the lady's 5th kid, okay? She's gonna deliver a lot sooner than if it's her first kid.
Or your last child was C-section.
Right. Yeah. C-section versus, like most little hospitals like this, if someone's had a C-section, they get another C-section.
Okay.
There's a, albeit a small risk, but it's a risk that if you try to deliver vaginally after C-section, you could tear those muscles and stuff that have already been compromised. So typically, you have to go to a big facility, St. Luke's or Cadlick, to do what's called a VBAC, a vaginal pregnancy after C-section. Or if you're here, you just automatically get another C-section. So some other good ones, just to reiterate, like, how are you under a doctor's care? Do they expect any complications? If there is complications, what is it? If your water broke and they're like, hey, the baby hasn't turned at 7 months, which it might not by that point, that's a significantly different delivery, especially in the field, than if the baby's turned the right way. Okay, do you feel like you need to have a bowel movement? That's indication that the baby's traveling down and that could be an imminent delivery. The guest on here says poop, you have to poop, but you know, that sign of possible delivery.
Would you check for crowning on something like
If
that?
so, you would, if the mom is like, this thing's coming, like, then you would need to. If there's no indication like that, then I wouldn't. But like I've worked and I've gone to these calls in the field where the lady's like in a snowsuit, then she's in coveralls underneath that. And I'm like, oh my God, if you start delivering, I got to get like 16 layers of clothes off you here. So you might want to start working that way, get some of that off, but I would not check for that unless the mom is like, boys, we're moving along here, like the baby's coming.
What was the last thing she ate?
Good.
Indigestion.
Indigestion. Yep. Okay. So another scenario. So we've talked about stuff with abdominal pain, you know, chest pain. So you go to someone and they have shortness of breath. So what are some questions? What do you want to ask about shortness of breath? Someone's like, hey, I'm having a hard time. Their complaint is, I'm just kind of having a hard time catching my breath.
History respiratory illness.
History respiratory, is it asthma, COPD, something like that? Yeah, what else?
When it start.
When did it start? What were you doing?
What makes it worse or better?
Yep. Did they take an inhaler? If they sit there and put their arms over their head and try to catch their breath, does that help?
Are you allergic to anything?
Yeah, maybe something you got into.
Smoking history.
Yep. What else? Someone goes, hey,
Is there any pain with shortness of breath?
pain, good,
Check for fever.
perfect.
Anaphoresis.
Yep. Another thing too with shortness of breath, it could actually be cardiac in origin. So throw that 4-lead on them, check their pulse. They might be an AFib. They might have kicked into like an AFib with what's called RVR, rapid ventricular response. So they might have an irregular heartbeat at a rate of 140. And that's actually causing their shortness of breath because that irregular heartbeat, they're trying to catch their breath to oxygenate better. What else? What else would you ask someone that says they're short of breath?
Did you see Don changing his clothes outside his house?
That'll take anyone's breath away. Okay, so one last scenario for questions. And again, psychological, emotional issues is another category you might run into. So you were toned out to a 16-year-old that, whatever it is, let's say, just maybe made a comment like, I'm gonna hurt myself, okay? What do you want to ask there? What do you want to ascertain with a psychological emergency like that?
Well, if it's a psychological emergency and a 16-year-old, do you have the right to immediately treat without a parent? Or do we care about that?
Well, you do care, and you would treat it if mom or dad wasn't there, then you would just use what type of consent? Implied consent, yeah. Because we.
15 morning, right? Green team major?
Yes, 15 for them to ask.
Yeah.
18 to decline or refuse. But what else? So there's the minor issues, right, that we got to try to deal with. Hey, is it appropriate to call mom or dad? You should probably try to, unless they're like, no, do not call mom or dad, because maybe mom or dad is a contributing factor to this.
Have you overdosed? Have you taken any?
Right. So have you done anything to hurt yourself? And if so, what did you take? How many? Where's it at? Let me see the bottle.
Because it kind of goes back to what we were talking about earlier, that kind of gold, what I said gold road now.
Yeah.
Window of, 60, 90 minutes before they start digesting.
Right. Yeah. When exactly? Because poison control want to ask you that. When did they take it? Some other stuff on here. Sometimes this isn't the person's first attempt at doing this. You might go to these kiddos or anybody really. We just had the scenario of a kid, and you see superficial scars. They've tried to cut themselves before. Just other indications of a mental health history. But have they tried this before? What else? What else would you want to ask?
Why do you feel that way? Maybe.
Yeah, maybe just go, hey, what's going on? Sometimes you got to be careful. We are not psychologists or can't help them long term, but a lot of adults, we go to them and it might be a panic attack, and we might just say, hey, you have a lot of stress. Well, you have a 20-minute ride in, everything's done. Hey, what's going on? Most of the time, people will want to talk to you and kind of tell you. You don't want to get into too much detail, but a lot of times, guys, it's amazing. You get in the back of the medic. You're compassionate, you're there to help them, you're their advocate, and you said, hey, you said you're under a lot of stress. Can you kind of tell me what's going on? And, sometimes they might tell you to pack sand, no, but a lot of times, guys, people actually tell you, and you can just see that they really appreciate that. But you have this individual, let's say any individual now, beyond the minor thing that is overdosed or has an ideation of hurting themselves. What else could you ask? So some stuff, like I said, have they done this before? Are they under a doctor's care? Do they take any medicine, obviously, for this? Do they take anti-anxiety meds, things like that? Are they compliant with it?
Talking to a counselor.
Yeah. Is there someone that we can call for you? Do you have a counselor at the wellness center or whatnot that we could get a hold of? A lot of times, like in adults, they have to get up the courage to do this. So there's ETOH alcohol on board before they do that other drastic thing. So in alcohol and whatnot can actually, potentiate or whatnot, obviously cognitive ability, but those other meds that they might have taken as well. Have they ever tried this before? If it's something really serious, do you have a plan? Like, how serious were you about this? And like, yeah, dude, you see that rope and that beam? Like, I had it planned out. That's pretty serious that they got that far, that they had a plan. Some people, they might not get that far, but it's okay to ask them, how far did you get with this? Have you ever tried it before?
What medications they are, if they're on a blood thinner or something.
Yeah, so maybe whatever they did is going to affect their other completely separate medical history. Another good thing on here, hey, do you have any weapons on you? Sometimes we go to people and we don't have police officers. So the last thing you want to do is someone that has these ideations and you roll them into the ER and they have a nice big old pocket knife on them. I've actually, when I couldn't get police before, I've frisked people. I don't know what I'm doing, but I kind of know what to check. Pockets, boots, arms, whatnot, to try to look for those things.
There was a patient, I can't remember if it was mid-90s or just early 2000s, that rolled into St. Joe's in Lewiston. Dr. Kendrick, who was the ER physician, was on. They had him all wrapped up and everything. They didn't search him. Mm-hmm. When they unwrapped him, he had a big old butcher knife. He went out and he went after Dr. Kendrick with that thing. Mm-hmm. It was wrapped up with him.
Yeah. And you can get on YouTube, you guys have probably seen it, it's been on lots of stuff, but this guy made it all the way through police custody. Like he's sitting in an interrogation room, the cop hands him a bottle of water and steps out, the guy drinks his water, pulls a gun out of and he shoots himself. But people can sneak this stuff by. Be really careful of people want to take backpacks, things like that, if there are any situations. I would actually try not to take them, but a lot of times that's all these people have. So want to be real careful with what you are allowing to be transferred with that patient in backpacks and stuff. So again, you guys, as you go through this and you go through your careers, you're just going to get better at asking questions, but you need to have a baseline of where to start, especially with your medical scenarios. You get points every time you ask a question. So if you roll in and your proctor's like, man, this guy asked 10 questions, he knows that's another thing that goes, he's pretty confident in this part of this, because you're going down the right track. So remember too that we want to ask some pertinent negatives. Remember, pertinent negatives are things that we might be looking for that they don't have. So you might go to someone that just took a bottle of whatever. We'll ask them anyway. If it's a female, hey, any chance you're pregnant? Do you have chest pain? Have you had nausea? Did you take this stuff and have you thrown it up since? Because then it's impossible. It's absolutely impossible to know how much got digested, how much under the influence of it they are, if they've thrown up after they've ingested something. So you guys, that's it for tonight. I just kind of wanted to end with, especially after abdominal, lots of questions we could ask. 9 o'clock Saturday, lab, we'll meet here. I think we go through it'll be a couple hours. I think it's hematology and another lecture, and then we'll do some lab stuff. So with lab, with your skill sheets, we should be working on the 2 oxygen airway, so oxygen administration like we've done, putting in the OPA, NPA, bagging, and then we are well into medical scenarios. So based on what their complaint is, we need to be working on those, the questions you ask from the doorway, and then getting into the specific stuff per complaint. So we should be good on, or at least introduced to respiratory, cardiac, and now we've gone through abdominal pain. So you should be able to start trying to roll through that stuff.
Are we going to practice patient assessment?
Yeah.
Okay.
Yeah, now that we have a couple of subjects under our belt, now we can start throwing out scenarios. And that will be lab where, Casey, you're the patient. I'll pull him aside or give a piece of paper. Hey, you're the patient. You guys will come up with your skill sheet and work your way down the skill sheet like you're with a patient. And that's what labs are going to generate into, is these scenarios now that we have a couple under our belt. So if there's no other questions, we'll see you guys Saturday, 9 o'clock in here.
You said hematology?
Hematology, and I think there's one other, it's kind of another twofer.
Before you leave, I was going to talk to you real quick tonight, about 2 minutes. You got a chance?